All right. Thank you. Once again, good evening, everyone. Welcome back to our bi-weekly sessions. Great to have you here. The chat is open, so please put in your comments, suggestions, and answers, diagnosis. Without further ado, we'll start off with our first case, starting from Rainbow, Bangalore. Over to you, Dr. Rashmi.
Yeah, so this is a 2-year, 7-month-old child who actually had a drowning episode on a Saturday in one of the Bangalore lakes. I don't understand. Apparently, that many lakes are dry in Bangalore. You must have heard about the water scarcity we are having here. But I understand there are pockets of water in that lake. And following the drowning episode, he was admitted to our ICU with respiratory distress. And after that, he recovered fairly quickly. So he was admitted on Friday, and by Sunday, he was completely well and he was discharged. Then on Monday, he got readmitted with vomiting 3 episodes on Monday morning, and then he was fine, so he was sent back home. But then Monday night, he started having seizures with fever. So he had 2 episodes of generalized seizures, which stopped after injection lorazepam. Then after that, what happened was he continued to have lots of myoclonic jerks. Hence, he was given many other medications, and then he was intubated and ventilated and transferred back to our hospital. But the following morning, when I did EEG, the myoclonic jerks did not have an EEG correlate, suggesting that this is non-epileptic myoclonus. So immediately we came down on the medications and we came down to just levetiracetam and nothing else. And then slowly he was extubated. His previous history, he has a speech delay and a lot of aggressive behavior. But other than that, no other issues. Currently, I mean, we got discharged. He got extubated on day 3, and then he got discharged home on nasogastric tube feeding. He is very irritable, and he's not back to his normal self yet. He's now on levetiracetam and clobazam for those jerks. Our second admission, after second admission, he got an MRI brain.
So starting off, the central event is drowning. And then they come.
Yes, correct. Yeah. Started off with a drowning, and then 2 days later, he had this episode of vomiting and fever.
Any chest X-ray done by any chance?
Yes, the chest X-ray was done. The first X-ray, I don't know what it showed. The second X-ray had right upper lobe collapse and had a lot of changes on the right side.
Okay, all right.
Dr. Rashmi, I missed the point perhaps on the history. How long was the drowning episode? Is that known?
So the drowning episode, initially mother said was for 3 minutes. But later when we told her that it could be hypoxic related and all, she said it is 5 minutes. And apparently she had also lost consciousness.
Was there
However, the child...
reanimation?
Sorry, what was that? Huh?
Did he require resuscitation?
No, he did not require resuscitation, and only he needed oxygen. So the first admission, in fact, I was not involved at all. The PICU team managed him. It was only the second admission I was involved with.
Thank you.
Yeah.
All right. This is the second MRI. Is that right? Or you saw day 3 MRI?
No, we did only one MRI because the first time we did not, MRI wasn't done because he recovered very quickly and he was discharged home. So nobody, in fact, ICU consultant said that he was walking and he was smiling and asking for food and all that. So they didn't think anything was neurologically wrong with him on the first admission. So the MRI was done only on the second admission when he had the seizures.
So after how many days of the drowning?
So drowning was on Friday and this second MRI was done on Monday.
So first MRI
not Monday, sorry, Tuesday. So Friday, Saturday, Sunday, Monday, Tuesday, 5th day.
So first MRI was normal?
No, first time MRI was not done.
Okay, no, because you just mentioned second MRI, so yeah.
No, not second MRI. Only one MRI was done, and this was done at the second time. So.
All right. Okay, so I have diffusion and ADC sequences, and you can observe some cytotoxic edematous change in the subcortical cortical regions, bilateral hemispheres, frontal parietal lobe, also involving the basal ganglia structures. And you can see on the ADC sequences, there's reversal or demonstrating cytotoxic edema, more on the subcortical regions rather than the basal ganglia. Corresponding flare sequences, again, the corresponding changes which you see on the DWIs, you have these edematous changes, subcortical cortical region also involving the deep gray nuclear structures. No abnormal herniations at this point. No. So even the T2s demonstrate the similar changes. Spinal cord was done. I don't have axial sequences. There is some motion there. I'm not sure if this is artifactual or real. It would be better corroborated with the axial sequence, but I cannot appreciate anything significant out here on these spinal cord images. I'm thinking, given the history, thinking of the possibility of hypoxic ischemic injury or anoxic injury, as I think someone also already mentioned on the chat, Dr. Vijay Sridhar. These are cases of hypoxic injury following drowning, and you can see the pattern. They have the Z-brain nuclear pattern, subcortical particle pattern. The subcortical particle is more along the partial prolonged ischemic. It can be more seen in the partial prolonged injury. But the changes, as we have seen in our case, possibly correspond with these images out here. The less likely possibility was post-ictal. They can also present with the subcortical cortical abnormalities and vestigial abnormalities. I think following this, the investigation was done. Dr. Rashmi, if you can just summarize
I think Dr. Karthik is here. Dr. Karthik, do you want to continue?
Yes, ma'am. So we did the basic investigation. CBC showed elevated WBC count, 14,020 cells, and with neutrophilic predominance. And CRP was positive, 13 milligram per liter. But serum creatinine, electrolytes, ionic calcium, magnesium, and LFTs done were normal. And CSF analysis was done, which showed no cells, and protein was 59, glucose 56, and lactate was 1 millimole per liter. And CSF culture showed no growth, and CHF HSV PCR was negative. And EEG, it was showing no epileptiform activity, but it was showing abnormal for age, and it was suggesting encephalopathy.
Okay, so the question I think Dr. Rashmi asked is, are these only related to the drowning event and hypoxic injury or anoxic injury or something else? Is that right, Dr. Rashmi?
Yeah, that was a question because our ICU consultant, Dr. Anupam, I'm not sure if he's here, he felt that the child had completely recovered when he was discharged on Sunday. And so does, I think, Dr. Karthik and the rest of the team. So they feel that the readmission when it happened with the seizure might not have been related to the drowning is what they were feeling because there was a complete recovery. So we looked through this. What I found out was if the drowning is more than 5 minutes, it can cause some sort of hypoxic injury to the child because the brain is sensitive. And yeah, so Dr. Archana is also saying the child did not have any loss of cardiac or no loss of consciousness in the first time when he was drowned. So the question was whether, GCS of 15 out of 15. So question was whether this was related to the drowning or whether this is something else.
Okay. All right. I'll open the case.
I think Dr. Udani has said delayed post-anoxic white matter injury. So how much delayed can that happen?
Usually 48 hours, 48, 72 hours.
Okay. So
I've seen that as well. Complete recovery following drowning and then kind of secondary energy failure within 2 to 3 days.
Okay.
It's not, I don't have a good explanation, but just by experience, this is very likely due to this drowning injury and not a second condition.
I see. Okay. So it may be that they have a delay in the presentation of the anoxic injury. Yeah.
Yes. Is this something related to something what we see in ALERD or the AESD type pattern? The initial images are normal, then on a follow-up, we have these typical diffusion changes. Dr. Vijay, any experience you have on the imaging aspects? I can see Dr. Vijay there.
I don't know because I have not seen, because most of the hypoxic patients will be sick by the time they present. Delayed presentation with intermittent and in between clinically sound is I have never seen.
Okay.
Good point.
Dr. Vivek, you wanted to say something? Yeah.
It was Dr. Vijay, sorry. Vivek hasn't joined us.
Okay.
Dr. Rani, sorry, you had something.
Yeah, I was just thinking, we had a patient of course, little different. He was hanging.
Yeah.
He was playing with a curtain and he somehow hung himself. And he was resuscitated. I mean, not resuscitated, but he was brought to the hospital. Everything was fine. Couple of days later, he had severe white matter injury, almost looked like ALERD, and then all cleared up after about few months. So, I mean, just with that, this was that time we were looking it up, and it looked like delayed post-anoxic. Now, why that happens? Is it because of some secondary a brain injury, possibly. I'm not sure.
Yeah.
Dr.
Or
Udani,
energy failure. Yeah. Sorry.
energy
Yeah.
failure. Would they need any special treatment if they have this delayed
No,
injury?
just supportive. I mean,
Just supportive
people are
only.
using all sorts of drugs for neuroprotective strategies, but I don't know how much it helps.
Started on melatonin just 2 days back, just to see some neuroprotection. Melatonin has a lot of papers. Other than that, I have not given anything else.
Dr. Ashmi, the presentation is a typical post-Downing complications, fever, encephalopathy.
No,
fevers.
it's not typical at all, which is why we brought it up for this meeting. So generally, if you look into the papers on drowning, I think Dr. Archana has also looked into, what happens is that either they are very sick, they need resuscitation and they're very sick, and then they have this hypoxic brain injury, or they recover, 70% just recover and don't have any problems at all. Or they may have a few motor problems in the future, some sort of coordination problems and motor problems, minor problems they may have in the future. But
no, I was thinking the lung, could there be a lung infection which is causing the other symptoms in the brain? That's why I asked for a chest X-ray. Is there consolidation or any abnormality out there?
Only one lung it was there, and the child was maintaining saturations in air. Anyway, we treated the lung infection. We've given antibiotics for 2 weeks now.
So that can explain the fever. Yeah, sorry.
Sorry. There's an article on this. I was just looking it up because delayed hypoxic leukoencephalopathy, they've been using antioxidant therapy. So they've given vitamin E, C, B complex, and coenzyme Q. And this happened 10 days after hypoxic injury.
Oh, okay. Something like what we gave was mito cocktail, something like that.
I can send you the article.
Yeah, please do. Thanks, Dr. Vivek.
Okay. Dr. Archana says child was normal on ventilators, minimal ventilator settings, mainly ventilated due to status. Should we do an MRI in 24 hours? The child was discharged at 24 hours. The child was.
No, Dr. Archana is asking, should we have done an MRI the first time round? That's her question. Because I told you, first time the child was well and then they were discharged. So I was not involved the first time. Only when they came in with the seizure, that's when we got involved. I got involved. So she was asking whether MRI is recommended for all children with drowning in the first 24 hours.
I think if they had neurological symptoms, definitely yes, and especially status, it is telling that there is a hypoxic event. To assess and counsel, we should have definitely done MRI.
And drowning for 5 minutes, even though, that's a pretty.
Timelines are not clear sometimes in that situation, but any neurological event definitely allowed.
So there was no neurological symptoms, Dr. Lokesh. I was not involved the first time, but what they're saying is there were no neurological symptoms. And initially,
there was no status. What was the status?
Mother said 3 minutes, but she changed it later after the child was readmitted.
Okay. No, first admission, there was no status epilepticus.
No. First admission was for respiratory distress.
Okay. So we are with consensus on hypoxic injury or inoxic injury, slightly delayed. Dr. Ashmi, and I think Dr. Udani will share the article with you or with us.
Okay, fantastic. Okay, thank you very much.
All right. So no alternate diagnosis at this point of time.
Yeah. Okay, thank you.
Thank you.
Yeah.
Okay, Anas, over to you.
Good evening. This is about a 10-month-old male child born to non-consanguineous parents. Presented with had cough, cold, fever for 3 days. Followed his baby had fast breathing, for which the child was brought to the ER of the referral center, where in the ER he was noticed to have cardiogenic shock, respiratory failure, and metabolic acidosis, for which he was intubated and referred to the PICU of RCH. He was initially seen by the PICU team. He required inotropic support for 1 more day and was under sedation for the 2 days. On day 3 of admission, neurology consultation was sought because the child had paucity of movements. On examination, pupils were pinpoint, non-reactive. Doll's eye was absent, no gag. Heart rate was not reactive to painful stimuli. Both upper limb and lower limb were flaccid with no movements. Lower limb hamstring spasticity with brisk reflexes. triple flexion response was seen. So we had done, based on this, we had advised MRI.
Okay.
The bedside
MRI?
without a differential.
Yeah,
Nihal,
at
sorry.
that time,
Yeah.
at that time,
Yeah,
based
go
on
ahead.
yeah. So at this point of time, based on the rapid, cardiogenic shock, which was rapidly corrected in within 1 day of ionotropic support, and this absent reflexes, areflexia, flaccid areflexia, we thought possibility of rhomboencephalomyelitis based on the epidemiological as well as the clinical presentation. Probably the cardiogenic shock being a part of brainstem involvement.
All right. So MRI, I have diffusion sequences, confluent abnormalities out there in the perioronic regions going up to the cingulate cortex. Some punctate abnormalities involving subcortical white matter on both sides. Again, you can see in the cortex involving the frontal lobes, some punctate abnormalities along the thalami out there, the right basal ganglia, the globus pallidus. Predominant changes in the brainstem, as Anas has pointed out clinically, the possibility of the predominant changes out there. You can see diffusion abnormalities in the midbrain, the dorsal pons, the medulla involving the bilateral hemispheres, predominantly the inferior cerebral hemispheres. T2 sequences, again, corresponding changes which we've seen on the diffusion sequences. Again, edematous changes, more confluent in nature in the along the superficial aspects, but predominant changes are in the brainstem, the cerebellum, and if you see the cervical sections or the sagittal sections, you have these the cord edematous changes, almost involving the entire cross section of the cord on the axial sequences. And there was no optic nerve abnormalities in terms of edematous changes, so we did not do a contrast, if I'm not mistaken. On the SWA sequences, we had these hemorrhagic foci involving the brainstem structures, that is the dorsal pons, and also the medulla. At this point of time, I think, Anas, I think we thought of possible viral etiologies, the necrotizing encephalitis, as the imaging differentials, and then I think we had further follow-up. Anas, if you can just.
During the initial multi-organ dysfunction, we had hepatitis and oliguric, but these things were improving. Pro-BNP done at the admission was 30,000. LGPT was 1,200, 1246. LGOT was also elevated, so 1716, 718. IL-6 was elevated at day of admission. It was 1191, which on day 4 became 23. Child was metabolic acidosis with bicarbonate of 11. From the tracheal secretions, we had got enterovirus. So that was the so it was like a viral rhomboencephalomyelitis. So here, because when we had seen the child already, it was day 4.
Yeah, Anas, before you go to the next, there are some questions of CSF. Was the CSF done?
No, CSF.
Okay, cardiac examination.
Yeah, 2D echo after 2D echo initially LV dysfunction, but on follow-up it resolved.
Okay, evidence of sepsis.
PCT was high, child had fever,
Okay,
high grade
sorry.
fevers.
Okay, all right, go ahead.
Yes.
Nihaal and colleagues, can you try to help me to explain the imaging pattern? Is that the result of the infection initially, had fever and cough and so on, and then this child had a prolonged episode of shock and failure and so on, so likely, I think, hypoxic ischemic event in addition? Are we seeing kind of double trouble, or is that mainly the residual change following that shock and that difficult situation? I mean, if you bring in another metabolic condition like POL and so on, for me, it's getting even more complex.
So you're saying hypoxic injury without involving the basal ganglia and involving the brainstem structures and cerebellum? Is that right, Aigen?
The cerebellum can be hypoxic. I mean,
Yeah.
there are watershed infarcts in the cerebellum which look exactly like this.
Yeah, but I would possibly expect the more common structures to be involved along with the cerebellum. Wouldn't that be the sequence of changes, like the thalamus, the putamen, and then going up to the basal ganglia? I mean, the cerebellum and brainstem.
I just don't understand.
So if you're thinking of hypoxic injury, a severe hypoxic injury, would there be sparing of the deep gray nuclei and then only, then involvement of the the posterior fossa. That would be slightly atypical, wouldn't that be?
Yeah. We had few children with rhomboencephalomyelitis who presented with cardiac events. And that is why we actually clinically also suspected this, and very significant inflammatory response was going on with proBNPs going very high, PCTs, and the interleukin 6 in 1000. So this is on day 1 of admission. So although he didn't have any cardiac arrest or any, this one he had a significant cardiac hypotensive event, which didn't lead to any arrest. So no pulseless state to lead on to any cardiac related event. And these are not exactly border zone ischemias as well.
Now, can I ask a question, please?
Yes.
Yeah, Rajesh.
No, I was just wondering, it's very unusual for this. It's like peri-Rolandic changes. Normally, enterovirus, yes, can give rise to a brainstem encephalitis and even a myelitis. And if you have any axial cut of the spinal cord, is it? I mean, they are usually more anterior. Anterior changes because of So is it anterior or is it more posterior?
It is more. Almost involving the entire cord. The EV70 or 68.
Could it be something picked? I mean, severe infection with this precipitated some sort of metabolic disorder, like a Liege disease, because SIRF1 could come at 10 months.
Can it be a Golgi disorder? Can it be alpha Saturn locker precipitated by a fever? Because peri-Rolandic sign is there, dorsal brainstem is involved.
That's what I thought. Yeah, I mean, something like either SIRF1 or peri-Golgi, I'm not sure, but something of that sort.
Thalamus fade, Dr. Vijay. Again, some common imaging patterns. The pulvinar thalamic nuclei.
Yeah, that's it. Thalamus is fade, I agree.
Yeah.
And also some hemorrhage
And
may be there.
The hemorrhage again atypical would be, for mitochondria. The Golgi sign, as far as I know, it's more, I think, more confluent, right? These are more spotty kind of lesions in the peri-Rolandic region. So could these be small ischemic changes, and the rest is a rhomboencephalomyelitis kind of pattern? Okay, Anas, if you want to ask the query, and then Anas, are you there?
Yes, sir. So I just missed it. I could not hear it.
Yeah, no, the question here was management. We did the immunomodulation simultaneously, early IVIG and then the tocilizumab were given. But looking at the extensive brainstem involvement, we counseled about a long-term ventilation process possible because the child was very flat even on day 5. So the parents were not willing to give a long time in the corporate institute. So they took the child to a government place. So we have to get a follow-up.
Any follow-up after that?
This was
just this week, Rajesh, we have to get.
A couple of days back.
Because enterovirus in the trachea.
The strain, do we have, Anas? Yeah, sorry.
Sorry?
Do you have a strain? Usually the 6871 have more the focal involvement, as Dr. Udan.
No, we don't have strains. We don't have strains. From the PCR they have done, we don't have any strain. Or they are only isolated the enterovirus.
There's a query of osmotic demyelinations into many metabolic derangements, corrections.
Sodium was fine. There's no major sodium fluctuation, and even X-ray wise, there's only hyperinflation, not much a pneumonia patch or anything like that. Child required minimal ventilatory support, but AC on assist control.
Just an outside thought. Is it at all possible that this is an atypical? I know I've never seen it, but A&E.
I think we call that. I call it as a necrotizing encephalitis without the thalamic involvement, but the other patterns, the brainstem and cerebellar pattern, can be seen in A&E.
Except for the thalamus, everything else.
Yeah, except for thalamus, everything else. Yeah, fits into it.
Even the SGOT-PT is very high, which can also fit in there.
Yes, that was our thought process, like IL-6 and plasmapheresis. Only thing is, maybe child was like the diffuse brainstem involvement was a bit what was leading us to counsel the parents. Otherwise, we were wondering if the child had presented earlier. So can we go for plasmapheresis in such cases, and any role of giving early immunomodulation in such cases?
I think on admission, he was given low dose steroids and IVIG.
Yeah,
on day one.
1 gram, 2 gram per kg IVIG was given, and
5
1 mg per kg
milligram per kilo of methyl.
steroids.
Generally, steroids are useful, but there is some thing with enterovirus and steroids, no? That steroids can make enteroviral infections worse. But that's a bit of a controversy. I think you'll see that papers suggesting both. That's only one virus where they say that you have to be a little more careful. I don't know.
Yeah, the problem is we give it and then the diagnosis comes 4 days later. So,
exactly. Yeah. The second is you can have something like cytokine reactive syndrome, and these ones are very difficult. They can go very quickly. They can go into multi-organ.
I think that's what they were saying with the NEC or some type of cytokine storm.
Cytokine storm, correct.
Precipitated by some sort of infection.
thank you.
All right, thank you. All right, next case, so to Pune. Nitin, if you're there.
Yes,
Over
sir.
to you. Yeah.
Good evening, everyone. I'm presenting a 16-year male child who presented with a headache for 1 day. He had abrupt onset of weakness of left upper limb, left hand while writing exam. He was having a 10th board exam, and while writing the first paper, he noticed that he could not tie the tag of the answer sheet, and he noticed weakness of the left upper limb, and the weakness progressed to involve the forearm as well in a span of 3 days, and it was. And also, when he presented to emergency department, he did not have facial palsy. The next day on examination, we also noticed he had left UMN facial palsy with the House-Bachmann score of 3, which over 1 day, it reduced to grade 2. And the child was previously normal, no history of fever and no previous history of such episodes in the past. And
So sudden onset weakness, I guess, while giving the exam.
Weakness involving the left hand, then then the left ear.
And no predisposing factors, as you mentioned.
No predisposing factors were there.
Okay, all right, okay. MRI done at the time of day of?
MRI was done on the day of presentation. That was on day 2
okay,
of
same day. Okay, day 2. All right.
So this is something like stroke in evolution you are thinking of.
Yes, sir.
Because it's not very hyperactive to vascular.
Yes, sir. 1 day after over the night, the child had only weakness in the hand. Next day morning, by over 7-8 hours, he developed weakness of forearm as well at the level of elbow joint. Then we also could notice obvious weakness of the face upper UMN palsy of the left facial palsy.
Okay.
And it was static since then.
All right, I'll play the videos. Maybe you can explain.
See the left, there is division of angle of mouth towards right. However, frowning and closing of eyes were present. Only it was UMN kind of palsy of the left facial nerve, and weakness of the left upper limb. The distal part 2/5, and the forearm at the elbow joint muscles were showing 3/5 of power, and he could elevate the limb at the shoulder level. Beyond that, there was no weakness.
So any localizing areas based on the presentation?
Sir, subcortical on the right side, MCA territory could be the one of
okay.
arterial.
All right. Okay. All right. Diffusion changes, diffusion sequences out here, and you can appreciate multifocal abnormalities, concurrent abnormalities, predominantly involving the peripheral regions, that is subcortical, cortical regions, frontal lobes, the parietal lobes, some areas of the posterior temporal occipital regions, some punctate abnormalities involving the sphenium of the corpus callosum, the frontal white matter out there, the perisylvian region. So predominantly the territory is the watershed territory, predominantly external watershed territories with some punctate abnormalities in the white matter and the corpus callosum. Flare sequences, I think all of them correspond with the diffusion changes. I cannot appreciate any other abnormalities, local abnormalities to suggest that this is a multi-stage event. So the diffusion change on the right side correspond with the flare sequences. I think abnormal on the left, no abnormal herniation at this point, no significant mass spec. On the SWA sequences, I could appreciate some punctate foci of hemosiderin or hemorrhagic foci along the right parietal lobe out there. You can appreciate in the first two images. So some hemorrhagic foci in the subcortical cortical region and the sulcal spaces, and possibly in the right frontal region out here. So the predominant changes are over here in the right parietal lobe. The angiography did not demonstrate any abnormalities. I saw the source images. I could not appreciate any stenosis, thrombosis. The neck vessel also did not demonstrate any abnormalities in terms of occlusion or stenosis or thrombi.
Are they more tortuous, the smaller vessels?
Yes. Was on the left side especially, isn't that vessel very corkscrew kind of thing?
Yeah, I agree.
Which
the cortical one,
yeah.
Smaller vessels are definitely very tortuous.
Yeah, the peripheral ones. Got it. Okay, so imaging wise, there are watershed territory infarcts, but I think the workup, Nitin, if you want to just.
Yes, sir. On workup, he had vitamin B12 deficiency of 148. He's a vegetarian person, and MCV was 93. Homocysteines were a bit elevated, 74 micromole per liter. Cardiac evaluation wise, ECG, and 2D echo was done. That was normal. Doppler of neck and renal vessels were done. That was also normal. Lipid profile was normal, and ANA and lupus anticoagulant reports which came yesterday only. That was also normal, and he was started on ecospirin dose and other. Also, we wanted to know like the age of the infarcts and the differentials that we could be thinking of in such case, because cardiac evaluation wise it was normal, and other morphanoid habitus upper limb LS. Yes, sorry, sir.
How severe was the headache? Was it thunderclap?
No, sir, it was not thunderclap. It was actually he said he had that mild stress regarding the exams. That was the first exam that he was going to write off the 10th board. He said mild to moderate headache he had, frontal type, and that subsided on the first day itself without any further management. But a second day, that on the day of exam, he developed this. He noticed this weakness, sir. And morphanoid features were not there. Arm span and USLS ratio was normal, and his height was also normal for age. And ophthalmic examination was also normal.
Okay, case is open. Suggestions of B12 deficiency, hyperhomocysteinemia. Sridhar has mentioned, ISA has also mentioned the same.
Can you show us that cartoon you had after this slide?
This is just the imaging pattern which we see, the cortical and the internal watershed territories. The predominant causes mentioned are hemodynamic causes and embolism or microembolism. So our case has predominantly external watershed territory infarcts.
Thank you.
Then there's a suggestion of B12, homocysteine, B6, Dr. Vijay, sorry.
Is there collagenopathy possibility because of this vessels and some?
But these are external carotid vessels, no, can be normal.
Yeah, that is what I was.
B12 deficiency is the commonest cause of stroke in India. No?
Yeah, there's some hemorrhage. How do you explain that? That's a hemorrhagic. Is there any chance of this being a venous infarct?
That would have possibly picked, I mean, given that extent of the infarct would have been possibly picked up on the T1s, T2s along the sinuses. But I mean, they look more watershed, arterial watershed. Hemorrhage, I mean, we see those type of pattern vasculitis. Dr. Vijay, if you want to comment upon that, or microangiopathies.
No, can it be just a thrombus embolism and then
embolism? Yeah, that is causing. Yeah,
and
the most common explanation is the
cleared. That can produce the hemorrhages, no?
Yeah.
Yeah.
But how will you explain the headache? Because of what was the hemoglobin level like? Was it high or?
Hemoglobin was 12.7 gram per cent, sir, and vitamin B12 was on the lower side, and
so homocysteine is normal or abnormal? Sorry.
Homocysteine is 74, sir, elevated.
Very high.
Okay.
Almost looks like a CBLC deficiency, except that it's an older boy without any problem before this.
Daniela mentions that normal angiography doesn't exclude vasculitis, need to do vessel wall imaging.
Okay.
So we conclude that these are arterial infarcts or related injuries, possibly microembolic related strokes, or possibility, and to rule out the possibility of vasculitis. No sign of venous thrombosis. Yes, I agree. And Peter mentioned CVS deficiency will have hyperhomocystinemia and increased methionine levels, which can predispose to stroke. So I think that tragic. I mean, you can follow that path then to evaluate for homocysteine, CVS deficiency. Methionine levels and vessel wall imaging is possible.
The angiogram was not done.
No, CT angiogram was not done.
Sometimes RCVS can show up in the second MR. Initially, peripheral vessels are involved, and later on the central vessels. Maybe it's a bit.
But would that be? Have you seen unilateral involvement, Dr. Sudani? Predominantly sees bilateral for RCVS.
Yeah, you can get a stroke unilaterally, but usually, I mean, the vessels may be all over the place.
Vessels,
Which are the constrictions, but the symptoms may be only on one side.
Yeah.
And they can get hemorrhage as well.
Yeah.
I understand the thunderclap headache was not there, but who knows?
Not there. Yeah.
Maybe you can repeat an MR and see.
Okay,
or CT or whatever.
Yeah. Okay, Nathan. Thank you.
Thank you.
Next case also yours. So over to you.
A 10-year-old male, third issue non-consanguineous marriage, previously well child, normal development, scholastically normal, good. The child had trivial trauma to Naseon when he fell down, and it was at home while playing, and there was no history of fever or no history of rhinorrhea and or vomiting at that particular time. And 3 days later, after the trauma, the child developed fever, and he had a headache, which was frontal and parietal bilateral, and mild to moderate intensity. And he on the day 3 of illness, he had altered sensorium, and for which he was admitted in hospital, and he was worked up there, and CT was done. That was reported as normal. He was treated in line of meningitis. However, his condition did not improve, and he received IV antibiotics, and he was referred to Bharati Hospital on day 3 of illness. And on examination, his GCS was poor, 6/15, and there was neck rigidity, and features of raised ACP were present, and he was intubated, and he was admitted in PSU. EG was done suggestive of moderate encephalopathy. However, there was no seizure or electrical seizures or NCSC, and the encephalopathy worsened, and his raised ICP was also refractory to IV mannitol and or hypertonic saline and other conservative measures.
Okay. No craniotomy done. I think we had a case previously to relieve the pressure. Not mistaken.
Yes, sir. Craniotomy could not be done. Expert opinion was sought. However,
okay.
I said it could not be.
Okay. So I have, I think, only the MRIs. I think a CT was done after the MRI, which demonstrated severe edematous changes and coning and herniations. So diffusion sequences, you have multifocal abnormalities, again, the deep brain nuclei, bilateral size subdural empyemas out there. You can see there is restricted diffusion along the subdural collections. Some multifocal abnormalities in the bilateral hemispheres, also involving the brainstem structures, that is the midbrain on the left, and the bilateral inferior cerebral hemispheres and cerebral white matter. Some prominence of the lateral ventricles, but yeah, these are the main findings on the diffusion, which I could see. And on the SWA sequences, there was again some areas of linear hemorrhagic foci out there on the right parietal lobe. The bilateral deep brain nuclei had these punctate and this more focal abnormality on the left thalami. And then again, punctate foci on the bilateral cerebral hemisphere. Theta sequences, some degree of volume loss, cortical volume loss, but again, predominant changes in the deep brain nuclei. Some hypointensity along the left thalamus, which corresponds with the SWA sequence of likely hemorrhage out there. Again, brainstem abnormalities, cerebellar abnormalities. A spinal cord, I don't think I have an axial, but there was some linear hyperintensity along the anterior or ventral aspect in the thoracic region. I think axials would have been helpful out here. Post contrast, again, could appreciate some degree of meningeal enhancement, especially on the left hemisphere, the frontal region out there, the leptomeningeal areas of the left frontal region, the perisylvian region, superior perisylvian region. Some degree of enhancement, incomplete enhancement along the bilateral thalami. You can see more complete ring on the right side. So pachymeningeal enhancement, leptomeningeal enhancement, predominantly on the left side. Some degree of enhancement in the deep brain nuclear structures. And over here on the ventral brainstem, you can see that it's not very clear, possibly some degree of mild enhancement out there. At this point of time, there is no abnormal herniation. Angiography, time of flight angiography was done, and I could appreciate some abnormalities out there especially in the central regions, the central vessel circle of Willis, some beaded appearance out there in the middle cerebral arteries on both sides, and also involving the right vertebral artery. If you see, it's smaller and some degree of abnormality in the peripheral regions. So beaded appearance of the middle cerebral arteries, the circle of Willis arteries, the anterior cerebral arteries, and possibly the right vertebral artery out there. CSF was done, and Nitin, over to you. We are dealing with infective focus primarily. Yeah. Sorry.
They were admitted outside hospital. The report with which they had come with CSF report showed cells of 4 all over lymphocytes, and CSF chemical biochemistry showed glucose of 3 and protein of 11. Culture having no growth. This was when they presented, and we had done MRI, and meanwhile workup was done. However, on day 3 after MRI, we repeated CSF with mannitol cover, and that showed 2,500 cells with neutrophils of 90% and biochemistry of glucose of 63 against 127 serum, and protein elevated. And culture also showed streptococcal pneumonia. Before that, we thought, before getting the culture that came out to be, we thought of NEC and other para-infectious or viral meningoencephalitis, but these were the pictures.
Okay, so your main question is any query? I mean, does the streptococcus explain the entire?
Yes, sir. Yes.
Yes, it does.
Or yes, yeah, Dr. Udani, yes, yeah, yes, sir, yes.
Oh, there is this condition, post-pneumococcal meningitis,
Meningitis,
secondary cerebral vasculitis.
Okay, sir.
Bad news.
Any microhematuria question from Aisa?
No, renal was normal, no microhematuria.
Out of interest, was he immunized?
Sorry, ma'am.
Was he immunized against?
No, ma'am. No, he was not immunized for PCV. However, routine immunization were taken till 1.5 years of age.
Okay. So I think the organism explains the imaging findings. Sridhar mentioned that we had a case of nephrotic syndrome with streptococcus and vasculitis. Child is in status dystonicus with cerebral atrophy. Was steroids given? Question from Ali.
initially were given of low dose steroid 3 days.
Dexamethasone. Dexamethasone was given initially.
Okay.
The outside CSF report was a little confusing, sir, initially. So it took a little bit of time to reach the diagnosis.
So it's a false negative, or was it a faulty
We
specimen?
are
Or
still not sure, but the glucose of 3, the pathologist was sure about that. So we were thinking, yeah. And there was no growth as well. And this CSF was done when the child had florid meningitis symptoms outside also.
an MRI was reported as normal, is that right?
A CT was done outside, which was
CT,
reported
okay.
as normal. Yes.
And the follow-up CT demonstrated diffuse edema.
Yes,
Is
yes.
that right?
After this MRI, 2 days later,
Okay.
a child had angle herniation.
Okay.
We couldn't get a decompression. Yeah.
Okay, I think we agree that the organism can cause all the imaging manifestations. Okay.
Thank you, sir.
Yeah, maybe we'd like to see the first CT here. Pretty sure there could be some abnormality if it's presented with florid meningitis. Hopefully, we didn't miss out on anything.
Okay, we'll try to get that.
Yeah. Okay.
Thank you.
All right. Thank you, Nitin. Thank you, Krishnapriya. Apurva, over to you.
Yes, sir. So this is a 4-year-old female child who had a history of mumps for a week. Following the mumps infection, it was resolving. After a week, the child developed difficulty and pain while she was walking. Within 1 to 2 days of this episode, they noticed that there was sudden onset seizure followed by encephalopathy, such that the child had to be intubated in view of poor sensorium. While the child was on ventilator in the outside hospital, the child was being managed. They noticed that after the seizure was managed, the encephalopathy was becoming a little better, though not complete to the baseline. But there was some improvement in sensorium, some spontaneous eye opening, facial grimacing, but the child was not recognizing parents. But at this point, they noticed that the child had complete flaccid paraplegia. The child was not able to move limbs at all. During this time, the child was managed as GBS, and the child was given IVIG. They also did CSF analysis and CSF studies, which was normal, and CSF biofire, which was also normal. Almost into 10 days of mechanical ventilation in the outside hospital, they referred to our hospital in view of no improvement in the symptoms. When the child presented to us, the child had eye opening was present, but child was not recognizing parents. There was facial grimacing to painful stimulus. Asymmetric pupil were there. Left 2 mm, right 3 mm, but both were reacting to light. There was continuous drooling of saliva, and there was no cough reflex. The child was not triggering above ventilator, and there was complete hypotonia, absent knee and ankle jerks, and planters were mute, but SLR was positive. So at this point of time, because the child was already into 10 days of mechanical ventilation, we got tracheostomy done, and then the MRI was done. The first MRI was done on day 1 of illness, which was normal. This is around day 10th of the neurological illness that we did the repeat MRI.
So there are total of 3 MRIs, Apurva? I have 2 MRIs with me.
Yes, so the first one was in outside hospital. We had
okay, that was normal. So this is day
10th first MRI.
Okay. All right, day 10 of illness, diffusion and ADC sequences, some degree of abnormality in the white matter. Some areas demonstrate distributed diffusion, especially subcortical regions. You can see in the temporal lobe, they have these bright signals on the on both sides, which show low signals on the ADC sequences. The corpus callosum also, the posterior aspects demonstrate some degree of diffusion, low signals on ADC. The cerebellum is bright on the diffusion sequences on both sides, with some areas demonstrating the reversal on the ADC sequences. The T2s and flare give a better picture. There is some degree of cortical volume loss, some degree of white matter changes, confluent abnormalities in the frontal parietal lobes. Cerebellum, especially the white matter and the dentate nucleus, demonstrate these hyperintensities. The pons also is slightly bright for the age. And on the flare sequence, again, you can appreciate this almost leukoencephalopathy type pattern involving the bilateral hemispheres, more deep white matter, subcortical white matter, and the peritrigonal white matter. cerebellum is on the flare sequence. As you can appreciate the hyperintense changes, especially the pons and also the dentate nuclei and the cerebellar hemisphere on both sides. So we did the spinal cord, and the side sequences, you can appreciate that there is this cervical cord and upper thoracic cord is swollen. Also, the lower thoracic cord demonstrates some degree of hyperintensity. Corresponding axial sequences, again, you can appreciate almost polar cord involvement of the cervical cord, demonstrating the C2 hyperintensities. Some central aspects in the thoracic cord demonstrating hyperintense changes. Follow-up scan was done 10 days later. Anything in between, Apurva, in terms of neurology?
So in between, despite receiving IVIG and methylprednisolone, we were considering some demyelinating or encephalomyelitis post-mumps infection. The child had worsening of sensorium, which was little better. The child had no eye opening. The pupils were dilated. The child, there was deterioration of the sensorium, which was not there previously. So then, because of this persistence of upper and lower motor neuron signs, we did a follow-up scan.
And on medication, what was the medication child was on?
So we had started on methylpred already received in the outside hospital. We had given IVIG, and Plex was given the option, but because of financial constraints, we could not do that.
Okay.
So went ahead with IVIG.
Okay. Follow-up scan, nothing in terms of acute abnormalities on diffusion sequences, but you can identify there is again some progression in the volume loss. T2s again. So there are abnormalities in the white matter in comparison to the previous study. There's slight improvement. If you see, there's more patchy involvement now compared to the more confluent abnormalities in the previous study. The basal ganglia are more hyperintense now on the present study. There is progressive interval volume loss. I think child is on steroids, so hence that can be an explanatory for the volume loss. On the flare sequences, again, you can appreciate the deep brain nuclei changes, the cerebellar changes. On the flare, you can see that there is hyperintense changes on both sides. The pons also is that matter. So yeah, in terms of the white matter, there is some improvement, but the deep brain nuclear structures, basal ganglia is now showing some progression. The posterior fossa findings, especially the gray matter structures, the dentate nuclei in comparison to the previous study is slightly better. The medulla also is slightly better. We did not do a dedicated spine study, but as you can see on the spinal cord, in comparison to the first scan or the second scan done 10 days prior, you can see there is interval improvement in the cord appearance, the hyperintensities, and the swollen nature of the cord, which was seen in the first study. Mumps was given as a possible, so the parotid glands, at least some sequences did not demonstrate any changes of typical parotitis related abnormalities.
In terms of investigations, we sent serum mumps IgM positive titers, which they were 8-fold increase in the titer. CSF analysis was acellular, CSF biofire outside was negative. Serum NMO MOG we have sent, but the reports are awaited. So our main query was that whether this entire thing can be explained with just mumps infection, or we could consider any other possibility in this scenario.
Okay, case is open. Comments to look for MOG, to continue treatment, look for MOG. Mumps usually has aseptic meningitis and not such a fulminant picture. So these are just literature examples of mumps only based on imaging. They can have varied presentation, subcortical involvement, gray matter involvement. The question is it only infectious or is it parainfectious demyelination?
It's unusual to get, MOG-induced dentate nucleus changes. Am I right?
Yes, and so symmetrical.
And once you, unless it's MOG-induced encephalitis, which of course it could well be, where you get cortical, subcortical, and basal ganglia changes much more and all that, and they don't disappear with time. Otherwise, ADM, ADM goes away very nicely with steroids.
Yeah.
So I don't know. This looks like more than MOG. Who knows?
But the child is responding to some degree of treatment, at least imaging wise.
I know,
there was
but
some improvement.
mumps also will all these conditions, even if it's a para-infectious or some sort of mumps, they usually improve.
Yeah.
But clinically, there is no improvement in the child sensorium-wise, encephalopathy-wise. There is no improvement despite the medications.
That's what I'm saying. So that seems to be less likely for demyelination. Don't you agree?
Yes, sir.
It seems like some encephalitis.
Hmm.
Give us a follow-up if MOG comes positive. It should be really interesting.
Kudani, if mumps come in, if MOG comes positive and then we have an IgM, how do we attribute which one is positive?
No, so that probably it's mumps
Mumps
triggered.
induced, yeah.
Mumps triggered MOG antibody.
MOG. Okay.
And but probably would call it more of an encephalitis rather than a
Encephalitis, yeah.
demyelination.
Question of angio. Angio wasn't done. There is no we didn't check for angio. Any CSF pleocytosis, Apurva?
No, sir. CSF was acellular. No pleocytosis. Proteins were normal.
All right. Mumps encephalitis in chat. By Agnes. Severe ARDS. Okay, Anas has put that up. Okay, so we're going with encephalitis. HLH, improvement of HLH on imaging. I have not seen on an interval scan. Apurva, any idea? Do HLH, usually there's progression, I guess.
So, but even clinically, there were no other markers suggestive of secondary HLH, like any transaminitis or any other things.
Okay. So lack of CSF pleocytosis with normal protein is strongly against MOGAD. ASLR CSF rarity. Okay, so we're going with, I think, predominantly infective encephalitis pattern, and we'll check if MOG is positive or not. And as Dr. Udani has mentioned, not improving on steroids is slightly against a purely demyelinating process. Okay, if there are no further comments, we await the MOG NMO results.
Sure, sir.
HIV status?
It is negative. It is not reactive.
Okay. 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 Thank you. And I have one follow-up case. This was discussed in the last meeting. Anas or Harika, if you can just quickly present the case.
Yes, sir. This was a follow-up case that we presented in the last meet. Initially, the child presented with swelling of right eyelid for 1 month, and child had history of left eye proptosis that resolved with symptomatic management in 2021. In February, child presented with swelling of right eyelid for 1 month, which on examination showed convergence and also slight proptosis on right side. And on neuroimaging, it was S2 of LCH, and child was started on LCH treatment protocol, but there was no improvement. And now, child presented with acute bilateral painless loss of vision for 2 days. And on examination, hypertension was present, and bilateral pupils were dilated 4 mm and not reacting to light, and light perception was present. And so, in view of that, and the child had hypertension emergency and also complained of severe headache for 2 days. So we have done contrast enhanced CT.
Okay. So just to summarize the imaging findings, this was a post biopsy scan. As you can see, there is abnormality out there on the right orbit, the extracorneal space going into the sphenoid bone. And this was, I think, biopsy result had given us possibility of LCH, but not definite evidence. Is that right, Harika? Or was
Yes, sir. Yes, sir.
Yeah, and all right, CT also, we don't have a CT, but they demonstrated lytic lesion in the hyperlateral bone.
Yes.
At that time, yeah, we considered possibility of LCH based on the biopsy and the imaging finding. I don't have images, I just have the videos. This is the non-contrast CT. Apologies for the lines, but I could not appreciate any interval changes, at least on the non-contrast scan, other than the volume loss. Look at the contrast sequence, sorry. Contrast again, cavernous sinuses, there's some enhancement, some pachymeningeal enhancement, which was also seen on the previous scan. So no focal lesion in the brain. Let's see of the orbits. So on these cuts, again, I think the extent of the lesion is similar to the MRI in the right extracorneal space involving the rectus muscles and also the greater wing of sphenoid, the sphenoid bone. Soft tissue abnormalities, I think, are similar. There's no hemorrhage or any interval changes, at least on the CT scans. So then the question arises, what is the query? Harika?
Initially we were thinking it could be an infiltrative pathology, maybe lymphoma or Langerhans cell histiocytosis. But now, considering the background child is not improving and worsening despite on vinblastine therapy and steroids, we considered the possibility of it could be a fungal pathology, and we have sent beta-D-glucan and galactomannan. Galactomannan, we got it as positive 1.5. So child is on amphotericin B and voriconazole. And we have the previous biopsy which we have sent, we have asked the pathologist to look for fungal staining in that. So right now it's more of a diagnostic dilemma. Child is worsening, like vision loss is there and headache is there. Hypertension maybe probably because of the steroid, it's better now on dual antihypertensives. So we are wondering what part we can go, considering that we're still drawing blank despite a biopsy and a PET scan. We have sent whole exome sequencing, considering the possibility of it could be a primary immunodeficiency, maybe some T cell defect which we are missing.
What is the time period from starting to 2 months, 3 months?
Yeah, so it's almost now. It probably started in January, so it's almost like 2 months now.
Okay.
He had some intermittent relief earlier, but it was only sporadic. Now again, he is having headache. But now currently with antifungal, his headache is better, and the vision is the same. Is very slight improvement, but not much. We have done screening, ultrasound, abdomen, X-ray chest, but nothing specifically on that.
Okay, there are comments of leukemia, lymphoma, as differential rhabdomyosarcoma, and fungal healths, obviously, you mentioned. Yeah.
So more of a diagnostic dilemma, like in which direction should we go from here?
In terms of treatment, right, Anas?
Yeah, I mean, we are already starting on broad spectrum antifungals.
Okay.
But again, getting another biopsy would be difficult because what we got last time was a bone muscle. I think whatever was there in the specimen, it was not muscle, only bone, decalcified.
Yeah.
So that's the only. Yeah. So.
Yeah, Dr. Arvita says look for leukemia, chloroma, IgG4, look for IgG4 antibodies. Burkitt's lymphoma from Sridhar. Bone marrow, anything? I don't think
bone marrow was normal. It was done.
Okay.
Pathology team, it was normal. IgG4, we not. I mean, yeah, it was suggested to us last time as well. I think we should explore that possibility as well.
So if everything is ruled out, then IgG4 is the one. Diagnosis of exclusion, I guess. Let's see the MRI images. It does not restrict avidly, but there is some restricted diffusion. especially in the orbital areas. Okay, there was no post contrast. Embryonal tumors. So that's, I think, thinking of possibilities of IgG4, leukemia, lymphoma. Yeah, these are the considerations. Tolosan syndrome.
We'll review it. Thank you so much.
And fungal. And let us know what you call the fungal. Biopsy, the analysis of the biopsy.
Yes, and that might help us in some direction.
Sinuses are not clear, but they don't typically look like a fungal sinusitis type picture. I saw. And okay, I think we have no further comments for this case, and that is our last case.
Thanks so
And
much.
we'll meet again. Thank you, Anas. Thank you, everyone.